النهارده هنتكلم على التريتمنت اوف ادفانسد اند ميتاستاتيك HCC. هيكلمنا عن الجايد لاينز والتريتمنت اوبشن المختلفه في موضوع مهم زي ده الدكتور احمد علي عبيه، صديقي وزميلي الكفاح، مدرس علاج الاورام بكليه طب جامعه الزقازيق واستشاري علاج الاورام في المركز الطبي العالمي. ان شاء الله تبقى محاضره مفيده ونستفيد كلنا منك يا دكتور احمد. اتفضل.
Thank you, Dr. Ahmed, for your kind presentation. Okay. كده بقى كده السكرين واضحة معانا يا جماعة؟ Okay. Thank you, Dr. Ahmed, for your kind presentation. My task today is to discuss a very challenging area of treatment in cancer in worldwide and in Egypt especially is the HCC. And as we know, HCC account for about 90% of all primary liver cancer and is the third leading cause of cancer-related diseases worldwide. Treatment of HCC in the advanced stage remains a great challenge with few drugs approved. And recently, there have been multiple new agents approved and a positive result for emerging agents in clinical trials. The problem, or the main problem in HCC is we have two diseases in the same organ. We have cirrhosis, which is present in most of liver cancer, and we have a tumor. So the challenge is to treat the cancer and preserve the liver function in this cirrhotic problem. This is the risk factor of HCC, hepatitis B, hepatitis C, alcohol-related cirrhosis, and metabolic disorder. And as we mentioned, we classify HCC by, as we have two diseases, we classify the liver disease, the liver cirrhosis itself, by what's called child B classification. And also we classify the stage of HCC, or we classify the liver cancer by staging, as we will mention later on. This is a classification of the liver function by child B classification into child A, child B, and child C, based on multiple laboratory and radiological and the clinical manifestation like bilirubin, albumin, INR, and ascites and encephalopathy. This is the classification of the liver cancer itself by what is used worldwide and wide popular staging system, which is Barcelona criteria, which classify HCC according to the extent of the tumor into early stage, which is a very limited disease, can be treated by local treatment by resection or ablation or transplantation, and intermediate or Barcelona B, which is multinodular disease, which can be treated by locoregional treatment by TACE or TER, and Barcelona C, which is advanced disease with macrovascular invasion or metastatic disease, which needs systemic treatment, and Barcelona D, which is a terminal stage with decompensated liver, and the best option is the best supportive care. So we have systemic disease for two patients. The first patient is Barcelona C, which is macrovascular invasion or metastatic disease, or patient with Barcelona B, which is refractory to TACE and or TER. A very important point while treating HCC is moving from treating Barcelona B, which is locally advanced disease, into treatment with systemic disease for Barcelona D. As conventionally, patients are switched from TACE to systemic therapy when they become refractory to TACE, and you should switch from TACE as early as possible if the patient is refractory to TACE, and don't do multiple TACEs in order to avoid decompensation of the liver, and so the patient will become unsuitable for any systemic treatment. And if you switch early from TACE to systemic treatment, the patient will be eligible to first-line treatment, second-line treatment, and even third-line treatment. So the first question is, what is you prefer? Is a first-line systemic therapy for HCC, TKI, immunotherapy, or combination immunopulp with anti-VEGF? Till 2007, there is no active treatment for HCC except some chemotherapy agent with minimal response rate. At 2007, there is a new agent, multi-kinase inhibitor, is sorafenib, tested in a large trial, which is SHARP trial. This is phase 3 trial comparing sorafenib 400 milligram twice daily versus placebo. And as we see, the first time to achieve overall survival benefit in HCC in this trial. And at the same time, there was another trial which is called Asia Pacific trial, also phase 3 trial for Asian patient. As we see, there is significant result regarding overall survival either in the SHARP trial or in Asia Pacific trial with different success or different benefit for sorafenib. As SHARP trial has a multiple patient with hepatitis C positive and hepatitis B, but Asia Pacific trial, most of the patients are hepatitis B positive patients. Are all patients get the same benefit from sorafenib in the first line treatment? The answer is no. There is some subgroup of patients get a greater benefit than another group of patients. Some like is hepatitis C positive patient get a better survival benefit, reach up to 14 months from sorafenib, but patient with extra hepatic disease and macrovascular invasion and high alpha fetoprotein get a little or lesser benefit from sorafenib. After 2007, which is the year of approval of sorafenib in the first line, and for about 10 years, there is no any comparator to sorafenib for treatment of HCC. All agents didn't achieve any overall survival benefit versus sorafenib. Till 2017, with the result of REFRACT trial, which is a large phase 3 randomized trial, non-inferiority trial comparing lenvatinib versus sorafenib in the first line setting of hepatocellular carcinoma. Primary endpoint was overall survival, which is positive trial according to the design non-inferiority trial. Lenvatinib has median overall survival 13.6 versus 12.3 months for sorafenib. The trial was positive regarding primary endpoint. But what was very interesting in this trial is median progression-free survival and response rate. As we see, median progression-free survival for lenvatinib is double progression-free survival for sorafenib, and also overall response rate for lenvatinib is triple the response rate of sorafenib. For all patients, yes, for all patients regarding good prognostic factor or poor prognostic factor, lenvatinib was better in these subgroups, especially in patients with poor prognostic factor like portal invasion, extrahepatic disease, hepatitis B positive patient. So I think according to this result, if you have a patient with a good prognostic factor like liver limited disease, like hepatitis C positive patient, you can choose sorafenib for the first line. And if you have poor prognostic patient or poor prognostic factor in your patient like extrahepatic disease, high tumor burden, high alpha fetoprotein, hepatitis B positive patient, I think lenvatinib is a better option in the first line. This is a side effect. When also you select between sorafenib versus lenvatinib, you should also discuss side effect. We have hypertension, decreased appetite, hypothyroidism is more with lenvatinib, and hand and foot syndrome is more with sorafenib. This is a discussion we mentioned. This is a new era. Treatment of liver HCC was tested for TKI for a long period. And then for the last 3 years, single agent immunotherapy was a comparator for sorafenib, but in the last ESMO, all single agent immunotherapy failed to achieve any overall survival benefit versus sorafenib. But the idea here is to combine immunotherapy, single agent immunotherapy, with another agent that may enhance the efficacy of immunotherapy. And the most popular agent now with immunotherapy is the bevacizumab. Bevacizumab is anti-angiogenic agent with additional immune modulatory effect that can normalize the tumor vasculature and increase the T cell infiltration into the tumor, so act in synergistic way with atezolizumab. And this is the idea of a very popular now trial, which is EMBRAVE 150 phase 3 trial comparing atezolizumab plus bevacizumab versus sorafenib in the first line setting, which leading to FDA approval of this regimen, atezo plus beva, in the treatment of unresectable or metastatic HCC who haven't received prior systemic therapy. This is the first time to achieve overall survival benefit versus sorafenib in the first line setting. We have atezo plus beva overall survival not reached versus 13.2 months. Not only overall survival, but also progression-free survival was positive. Median progression-free survival is 6.8 for atezo plus beva versus 4.3, nearly the double. This is a patient characteristic which is well balanced between both group atezo versus cis, that also patient with Barcelona criteria A and B were included in the EMBRAVE 150. We have 15% of patient Barcelona B, and this means that patient failed on TACE. Please don't repeat multiple TACEs according to criteria of refractory TACE, and please move the patient to systemic therapy as early as possible to achieve overall survival benefit. This is a response rate of EMBRAVE 150, also positive result, and very interesting to see about 18 patients by RECIST criteria have complete response with atezo plus beva versus sorafenib is 0. This is a very interesting response rate. This is a side effect mainly for bevacizumab addition. This is the EMBRAVE 150 discussion. EMBRAVE 150 represent breakthrough in the management of HCC, almost on par with the SHARP trial. First time a treatment demonstrates superiority to sorafenib. We have magnitude of benefit with hazard ratio 0.68, 0.58. It speaks to the potency of this combination benefit comes with very good quality of life performance, very good safety profile. Atezo plus beva will become the de facto first line therapy in the majority of patients, but please be careful for the exclusion criteria of EMBRAVE 150. We should exclude history of liver transplant or severe autoimmune disorder, untreated varices. Actually, in my practice, I proceed first for upper GI endoscopy and varices ligation before starting bevacizumab. History of recent GIT bleeding, recent surgery, obstruction of intestine, uncontrolled hypertension, and the child B patient. This is the NCN guideline, the last version in August 2020. As we see, first line treatment, best option, category 1 recommendation, sorafenib, lenvatinib, atezo plus beva, all of them are category 1 recommendation, but we should notice that lenvatinib only in a child A, atezo plus beva only in a child A, but sorafenib may be child A or early child B. Also, we have nivo as an option for patient not suitable for sorafenib or lenvatinib. How to select between these 3 agent or 3 regimen with category 1 recommendation? You should combine the multiple factor like treatment factor, safety, efficacy, and the patient factor, liver function, comorbidity, tumor factor, extent of the liver involvement, and the portal vein invasion. As we discussed, sorafenib is less effective in patient with high tumor burden, patient with hepatitis B positive patient, or patient with high alpha fetoprotein, but lenvatinib is more effective in those patients. As this is mentioned before, let me move to second line. We have consideration to choose a second line after failure of the first line, we should discuss first line therapy success, duration of response, toxicity. We should also notice child B status after first line treatment, toxicity profile of the first line, contraindication, performance status of the patient. We have three main players in the second line era of HCC. We have two TKI and one monoclonal antibody. We have TKI regorafenib, cabozantinib, and ramucirumab as a monoclonal antibody. Regorafenib approved based on a large trial, resource trial. Ramu approved on REACH-2 trial, and the cabozantinib in the second line approved also in based on large celestial phase 3 trial. When comparing the three trials, there is a main difference in the trial is the inclusion criteria. Patient recruited for resource trial for regorafenib, they should had to have tolerated sorafenib with a dose more than 40 milligram. But REACH-2 trial, the first biomarker selected trial, including patient only, in the second line, patient only with high alpha-fetoprotein more than 400, and celestial trial, including all comers, irrespective of tolerability to sorafenib and irrespective to the level of alpha-fetoprotein, and not that, but also including a patient in the second and the third line of treatment celestial trial. This is the first one, resource trial, testing regorafenib in the second line versus placebo after progression on sorafenib. But tolerance of sorafenib more than 4 exclusion criteria for this trial. Patient not tolerate sorafenib excluded from resource trial. Primary endpoint was overall survival, which was positive. Median overall survival 10.6 versus 7.8 months for placebo, leading to approval in 2017. FDA approved regorafenib based on this result in the second line setting. Also, all subgroups regarding respective to prognosis have a benefit from regorafenib versus placebo in the second line. And as we know, regorafenib side effect mainly is hand-foot syndrome, diarrhea, hypertension, as we know. This is the second player in the second line is cabozantinib, is a multi-kinase inhibitor also. What is very characteristic in cabozantinib is that it is acting on MET, which is one of the mechanisms of resistance to sorafenib. So it is very effective for patient achieve a benefit of sorafenib and then progress on sorafenib. A celestial trial, including a patient irrespective to tolerability of sorafenib, unlike resource trial, and including all patient irrespective to alpha-fetoprotein, and including also patient receive 1 or 2 lines of treatment. So cabozantinib is used as a second line or third line. This is the overall survival benefit as a primary endpoint, which is also was positive. Cabozantinib achieved median overall survival 10.2 versus 8 months for placebo, with hazard ratio is about 0.76. So in Jan 2019, cabozantinib was approved in the second line for advanced HCC after failure of sorafenib. All subgroups, including a patient with extrahepatic disease, hepatitis B or hepatitis C positive patient, all subgroups get a benefit regarding either overall survival or progression-free survival. This is a side effect of cabozantinib. The third one is the monoclonal antibody ramucirumab. Ramucirumab is a second-line treatment in patients with advanced hepatocellular carcinoma and elevated alpha-fetoprotein following first-line sorafenib. Based, this is the REACH-2 and REACH trial. The difference is that in REACH trial, first trial for ramucirumab in HCC, including all patients irrespective to alpha-fetoprotein, but this trial, as we see, is a negative trial, not achieving overall survival benefit with negative B value. But when we, this is the intention to treat population also progression-free survival. But when we comparing subgroup of REACH trial get a benefit, positive result in patient with high alpha-fetoprotein, and patient with low alpha-fetoprotein below 400 have no survival benefit. And so based on this post hoc analysis, the REACH-2 trial design was start with primary endpoint overall survival for patient only failed on sorafenib, patient only with high alpha-fetoprotein, and REACH-2 trial, this is a characteristic, well balanced. The overall survival become now positive after selection with patient only with high alpha-fetoprotein. Also, ramucirumab in all subgroups get a benefit from ramucirumab in the second line, as we see. Also, positive progression-free survival result for ramucirumab, and all subgroup get a progression-free survival benefit, as we see. Regarding the response rate, very interesting. Overall response rate, we have 4.6 versus 1.1 for placebo. And this is a dose exposure and the relative intensity for ramucirumab, which is meaning that patient or percent of patient can take more than 85% of the planned dose of ramucirumab. This percent was about 98%. This means that ramucirumab is a very well tolerated drug, especially for frail patient. And as we know, the side effect of hypertension and bleeding risk and proteinuria will be managed by XBAR. The conclusion of REACH-2 met its primary endpoint, showing significant survival benefit of ramucirumab treatment in patients with HCC and high alpha-fetoprotein who progressed or were intolerant to sorafenib. Clinical meaningful benefit were demonstrated in secondary endpoint, including progression-free survival and the disease control rate. Ramucirumab was well tolerated with safety profile consistent with monotherapy ramucirumab treatment. REACH-2 is the first positive study in a biomarker selected patient population, demonstrating a significant and a meaningful overall survival benefit and a favorable safety profile in HCC patient with baseline alpha-fetoprotein more than 400, a population associated with poor prognosis. Also, REACH-2 confirms the efficacy and the safety observed in the pre-specified group of patients from REACH with high alpha-fetoprotein. This is a bold analysis of overall survival for REACH and REACH-2, combining patient in REACH with high alpha-fetoprotein and all patients with REACH-2, showing that median overall survival 8.1 versus 5 months for placebo with significant result. Based on this bold analysis, in 2019, ramucirumab was approved as a single agent for HCC in patients who have alpha-fetoprotein more than 400 and have been previously treated with sorafenib. Conclusion of the bold analysis, as we mentioned, the conclusion on ramucirumab: first, positive study in a biomarker-defined patient subpopulation demonstrated efficacy of agent can be augmented, validated and angiogenesis as a therapeutic target in advanced HCC, which is ramucirumab monoclonal antibody inhibit vascular endothelial growth factor receptor 2. Safety profile is distinct from other TKI, as we mentioned. It's very effective, very tolerable drug for frail patients. Ramucirumab is a monoclonal antibody, not tyrosine kinase inhibitor. So the notable side effect, hypertension, hyponatremia, and not exhibit other TKI-related side effects. So the rationale for TKI as a second-line therapy, positive beta plus atezo, is the main problem. Now, if you start, as we mentioned, all second-line trial, as mentioned now, is after failure of sorafenib. So what we do if the patient start with bevacizumab plus atezolizumab is a main challenging question now, with no strong evidence for answer. But regorafenib, cabozantinib, ramucirumab for high alpha-fetoprotein patient all demonstrated overall survival benefit in patient treated with sorafenib previously. Provides initial evidence that anti-VEGF therapy may be beneficial even after progression of prior anti-VEGF therapy in HCC. So if you use VEGF like sorafenib, you have a chance to achieve another benefit from anti-VEGF like regorafenib or cabozantinib. None of the TKI have been studied in the patient after bevacizumab treatment, and none have been studied in a large number of patients who received immune checkpoint therapy with intention that cabozantinib trial, Celestial trial, include a small number of patients previously treated with immune checkpoint inhibitor. So which anti-VEGF therapy should you choose after bevacizumab and atezolizumab? Traditional first-line TKI like sorafenib, I think sorafenib or lenvatinib can be used, or traditional second-line TKI like cabozantinib can be used. This is depend on the friability of the patient, the performance status of the patient, liver function. You can start with Tecentriq plus bevacizumab, and then the second line is sorafenib or lenvatinib, and then the third line is the other TKI. This is a checkpoint inhibitor in the second line, which is mainly failed to achieve any benefit in the second line, but this Keynote 224 phase 2 trial give a positive result, so have accelerated approval in 2018, but it's phase 3 trial Keynote 240 give a negative result. So as we will mention, NCN will put immunotherapy in the second line as an option based on phase 2 low evidence trials. This is the NCN guidelines last version. Second line option is regorafenib, cabozantinib, ramucirumab for high alpha fetoprotein patient category 1 recommendation. Lenvatinib, if you don't use sorafenib is the first line, lenvatinib is the second option. Nivolumab, Nivo plus EB, sorafenib in the second line if you use immunotherapy in the first line, pembrolizumab. So NCN putting sorafenib, which is approved for the first line, and lenvatinib, which is approved for the first line, put it also in the second line. This means that you can choose, you can use atezo plus beva in the first line, and second line you can choose sorafenib or lenvatinib according to the liver function, and you can delay regorafenib, cabozantinib, ramucirumab, or single agent immuno for the third line option. This is the diagram of ESMO GI per Barcelona stage. As we know, A and B, local regional treatment, after 2 or 3 days with undocumented clinical benefit, you can move to systemic therapy. Systemic therapy from the start for Barcelona C, sorafenib, lenvatinib, atezo plus beva. And after failure of the first line, you can move to the second line if the patient tolerate either regorafenib, cabozantinib, ramucirumab. The recent update is approval of atezo plus beva in 2020. Thank you. Thank you, Dr.
Thank you, Dr. Ahmed, for your comprehensive presentation. You almost covered most of the updates of the treatment options for the metastatic and advanced HCC patients, and away from the complications of the studies in the practice, would you sum up the treatment option for the Egyptian patient, which we can see in our clinics, who mostly have the tumor burden, mostly high tumor burden with attenuated liver function? Which is the best option, as a treating doctor for such patient in our community, and in the expectation for the treatment outcome for these patients?
Thank you, Dr. Ahmed, for your question. I think this is a problem of some failure of sorafenib in the first line in Egypt, because most of the patients in Egypt come to us in a late stage of cirrhosis and cancer. And so the liver function usually in early child B or late child B or child C. I think a very limited number of patients are candidates for first-line systemic treatment of sorafenib. But our experience in treating those patients learned us to start with the lower doses of sorafenib. This is because the cancer itself may affect the liver function by including a large part of the liver, and also the main problem is the multiple cases done by interventional radiologists. Yes, after I see some patient with 9 cases or 10 cases, and so this affects the liver function, and so this patient not candidate for the first line. But as we mentioned, not mentioned in this trial, there is some trials of immune checkpoint inhibitor in the first line, which was a negative trial, but gives the same overall survival benefit of sorafenib. But the design of the trial is negative due to the design of the trial. But we have nivolumab in the first line achieve about 16 months overall survival. So as if you return to the NCCN guideline, putting nivolumab as option in the first line, as we option in the first line for patient not eligible to tyrosine kinase inhibitor. So if you have patient with child A classification, you can choose between sorafenib or lenvatinib. If you have patient with early child B, you can choose sorafenib is better. If you have patient with extrahepatic disease not suitable for sorafenib, you can choose nivolumab as a first line option. But the best option now, best survival now, is atezo plus beva, but approved only in patient with a child A classification, not approved for child B.
Okay. Another notice, one of the most important side effects for lenvatinib is proteinuria.
Yes.
And I asked most of the professors, would it change this proteinuria the patients with borderline liver disease or liver condition from child A to child B, or may worsen the liver condition? The answer for them that we can reduce the dose.
Yes.
What should you answer for this?
Usually ramucirumab given in the second line treatment, I think only in patient with high alpha fetoprotein. Those patients very limited renal function, because this patient exhausted with the first line and also exhausted with the cirrhosis. I think those escalation is a very important. If you give a lower dose in the first cycle without any proteinuria, you should escalate the dose in the second and third cycle, because the efficacy is mainly associated with the higher doses of ramucirumab. So initially start with a lower dose.
You mean lenvatinib? The
lenvatinib, and also ramucirumab also in the second line, also the same side effect is proteinuria.
The same side effect.
Yes.
Okay. Thanks, Dr. Ahmed. And if there is any question from the floor.
عشان كده الدكتور احمد التو دوزز مختلفين في الفانتنب للبيشنت الاندر ويت والاوفر ويت.
Right. And now I think that there is no question from the floor. There is nothing to be sent. Thanks, Dr. Ahmed, for your time and for your presentation. And I hope when this is uploaded for the YouTube, we can all share it with our friends and colleagues. Thank you.
Thank you. Thank you, Dr.